Thanks, Vanessa. Welcome everyone again to the Orientation to Agricultural Worker Health webinar. My name is Katie Kahneman. I work here at the National Center for Farmworker Health, and I'll be your presenter today. There are three main learning objectives that we'll be covering today. So our hope is that by the end of our time together, you'll have a foundational understanding of agricultural worker health and the unique factors that impact this special population and their access to care. So we'll be talking about how the Migrant Health Program functions, how it's funded, and the services it provides to the ag worker population. We'll be talking about some of the data and demographic information about the agricultural worker population and how it impacts healthcare access. And then towards the end of the session, we'll share some NCFH agricultural worker specific tools and resources. So for those of you who may not be familiar, we are the National Center for Farmworker Health, NCFH, and we are a private nonprofit organization located outside of Austin in Buda, Texas. And our mission is to improve the health of farmworker families, and we do this by providing programs, trainings, technical assistance, resources, and many other things to our partners and health centers and other farmworker serving organizations in our network. And we'll be sharing some links throughout in the chat. So feel free to visit our website to learn more about NCFH. One way that NCFH works to address our mission is through the Ag Worker Access Campaign. The campaign was launched in 2015 as a joint effort by NCFH and the National Association of Community Health Centers, or NAC. We, along with health center staff and other ag worker advocates, knew that more could be done to increase access to quality health care for America's agricultural workers and their families. And the result was the Ag Worker Access Campaign. The goal of the campaign is to reach 2 million ag workers and their families served and families in health centers. And we've seen progress over time since 2015. This graphic on the screen shows UDS data, national UDS data on number of agricultural workers served in health centers. And you'll see we've had a nice increase and a couple of dips due to likely the impacts of the global pandemic. And we're really excited to see that the 2023 UDS data that came out this summer showed that we are back up and past our halfway milestone of 1 million ag workers served in health centers. And we thank you all for the hard work you do to serve agricultural worker families in your communities. And to keep this momentum going, we invite you to join the campaign and learn more about the campaign on our campaign webpage. So for today, this is a great webinar for new staff who are just starting their careers or journeys in agricultural worker health, and also as a great refresher for more seasoned staff. As we're going through information today, feel free to use the chat or the Q&A feature to share your comments or thoughts on information shared throughout the session. But one of the best ways to understand the Migrant Health Program and when and why it began is to take a look back at the history that led to the creation of the Migrant Health Program. So here on the slide, we have a timeline, and we're going to start pretty far back. So the United States has imported agricultural workers for a very long time. From our nation's creation, agriculture and the small family farmer have been considered essential components of our society. And starting in the 1850s, there were major advances in crop production, and crop production was growing larger and larger. And because of that, as crop production grew, there became labor shortages to work in the fields. And the demand for labor continued into 1917 when the US entered World War I. And in response to this, Congress passed the Immigration and Nationality Act of 1917. And this established a legal basis for the importation of about 70,000 workers from Mexico. And this was the first guest worker program in the US. So then again, the US entered World War II, commercial farmers faced a really high demand for their products without sufficient labor. And the US called on Mexico again to fill this labor void through the establishment of the Bracero Act of 1942. This was the largest guest worker program to date. And although the Bracero Act was originally created to meet those labor shortages in the World War II timeframe, the program ended up continuing until 1964, ultimately employing over 5 million Mexican laborers. Then in 1952, the H-2 program was established. This program is similar to the Bracero Act, but it requires a certification of labor shortage from growers and employers in order to legally import workers. And this program is still in existence today as the H-2A program, which a lot of you all may be familiar with. By 1962, many ag workers in the fields were experiencing harsh conditions, low pay, little access to care. And President Kennedy signed the Migrant Health Act in response to this, also known as the Public Health Act, Section 329. This authorized funds to create a small number of migrant health centers to provide preventative and primary healthcare services to the agricultural worker population. So this may be a new piece of information around how health centers, community health centers began, or some of y'all may know this. Feel free to let us know in the chat if this is new information to you. But the migrant health centers in community health centers used to only serve agricultural workers originally, and therefore operated only during the agricultural worker season. But as you can imagine, this created a community sentiment of preferential treatment to agricultural workers within these communities where migrant health centers were located. And community members, they wanted access to these health centers too. So in response to this, the federal government made money available to health centers already receiving migrant funding to also serve the community in general, jointly under Section 330 of the Public Health Services Act. So this meant that health centers receiving federal assistance under Section 329 and 330 were under obligation to provide services to both agricultural workers and the community as a whole. Although some health centers have continued an excellent job in maintaining a focus on that original mission to serve agricultural workers, others have been overwhelmed by serving the community as a whole and challenged to maintain that level of focus on the agricultural worker community. This problem is further aggravated by limited resources available to provide outreach, translation, transportation, and other enabling services that are needed to reach hard to reach populations like our agricultural workers. So in 1996, Congress approved the Health Center Consolidation Act, which authorized the consolidation of Migrant 329 funding, Community 330 funding, and Homeless 340 funding, sections of the Public Health Act, to all be under the umbrella of 330 programs. So under this consolidation, migrant health funding was integrated into community health funding and also expanded to include aged and disabled agricultural workers. So Section 330 of the Public Health Services Act defines the Health Center program as a funding opportunity for organizations to provide healthcare services to underserved populations as a whole. So these are really kind of the high key points of the history of the Migrant Health Program. And there's a lot of more detail and nuance and other milestones that can be explored further. And we have some resources on our webpage to take a deeper look into the history if you're interested. But this gives us a good general understanding of how the Migrant Health Program began. So from the Consolidation Act, there were several definitions that were created for health center programs to, one, define agriculture, and also the creation of the three classifications of agricultural workers. So we'll look at those two definitions right now. So as defined in legislation, the exact legislation is here on the slide. The term agriculture means farming in all of its branches, which includes cultivation and tillage of soil, production, cultivation, growing and harvesting, and any practice, including preparation and processing, performed by a farmer or on a farm. And so this is our legislation definition. And then also through this legislation, the Consolidation Act defined the three classifications of agricultural workers for the Migrant Health Program. And that includes migratory workers, seasonal workers, and our aged and disabled former migratory workers. So these definitions become very important to understand when we're doing identification and reporting of our agricultural worker patients in your uniform data system reports. And we have an upcoming webinar on November 6th that will dive into these definitions and the ag worker identification process next month. So in our next section here, we're going to take a look at ag worker demographic data. So a great way to understand the agricultural worker population further is to take a look at what data and information we have on the population. So the information we're going to be sharing on the following slides comes from the National Agricultural Workers Survey, or the NAWS data. And this survey collects information on demographic data, employment data, and health characteristics. It's a survey that's conducted annually, and it's a random field survey. The results are not published each year. So this data is coming from the 2020 survey. And there is a link to a fact sheet that summarizes the data in the chat if you want to take that away with you as a resource. And we hope to update this data in the coming years with more up-to-date information in future webinars. But we'll go ahead and get started with some of this general demographic information. So looking at age, the average farm worker is 41 years old. About 67% fall between the ages of 25 and 54, and roughly 1/3 of agricultural workers are younger than 35. When looking at gender, about 66% identify as male and 34% identify as female. Looking at ethnicity and race, 77% of agricultural workers identify as Hispanic, and among US born workers, 30% self-identify as Hispanic. With dependents, more than half of agricultural workers are married at 57%, and about half of agricultural workers are parents. So taking an additional look into the demographic information, looking at income, education, language, and healthcare utilization, about 20% of agricultural workers income falls below the poverty line, which is an annual income of less than $30,000. Education level, the average educational attainment is about 9th grade, and 35% of agricultural workers reported completing 6th grade or lower. And language, Spanish and English are the primary languages reported by agricultural workers. 62% reported preferring English as their speaking language, and only 27% preferred English. And among workers born in Mexico or Central America, nearly all reported that Spanish was their primary language. This was 93%. And although we know Spanish and English are the primary reported languages in this population, there are a number of other languages that we need to consider, and that's Haitian Creole and other indigenous dialects and languages as well. Healthcare utilization. So 71% of agricultural workers used healthcare services in the US in the last 2 years. 26% reported paying for services out of pocket, 24% used Medicaid or Medicare, 16% paid using a personal or family insurance plan, and 11% reported not being charged for their visit. So next, we're going to look a little bit closer at employment and housing. When it comes to employment, we know there are a lot of factors involved, whether it's seasons, market demands, weather, year-round work is not always possible due to the nature of agriculture. So working hours can vary a lot. About 40%, 42% work more than 8 hours a day. On average, workers work 35 weeks of the year in agriculture and 6 weeks doing non-agricultural work, and about 9 weeks unemployed in the United States, and an average of 2 weeks per year outside of the United States. Looking at migration patterns, about 13% of agricultural workers are migratory and 85% of agricultural workers are seasonal. Of those migratory agricultural workers, 47% were domestically based and 42% were international. And 11% of the migratory workers had been in the United States for less than a year. So looking at work type, a pretty even split, 28% reported working in fruits and nuts, 20% reported working in vegetables, and 24% reported working in horticulture. And housing, 30% of agricultural workers reported living in a crowded housing situation where more than one worker shared the same room. And 14% live on a farm of their current employer in employer-provided housing. So in this slide here, we have a graphic that depicts migration trends. So there are 3 traditional main streams of migration that you can see on this map. The Western, Midwestern, and Eastern, with California, Texas, and Florida being the most common states for starting points. And it is estimated that there are about 10 to 13% of agricultural workers that are migrating internationally because of the H-2A program. And about 13% of crop workers are H-2A workers. So this information shows a lot of the traditional patterns of mobility, but we know there are lots of different patterns that agricultural workers and their families travel with. So now we're going to take a closer look at working and housing conditions now that we've looked at some of the data, just to kind of set the stage, get to know the agricultural worker population a little bit better. And so now we're going to kind of look at what are those working conditions and housing conditions that agricultural workers are facing, and how does that impact their access to healthcare and also the health conditions that they're experiencing. And it's really important for those of you working at health centers to be familiar with some of these conditions, barriers to care, and possible health conditions due to their working and housing conditions and occupational risks, because that can help us to better identify what their needs are, better provide care to them, and make sure that diagnoses are accurate as well. So starting with working conditions, as we know with agriculture, availability of work depends on the season, weather, and market demands. Hours can fluctuate a lot. They can start in the early morning all the way into the evening hours. Sometimes work is done every day versus 5 days a week. And there's a number of different income methods. Some workers are paid by the hour, some are paid by the piece picked, and sometimes salaried. And 86% of ag worker households reported not receiving a benefit of a needs-based program in the past 2 years. The majority of agricultural worker families do not receive benefits from their employer. So, adequate, affordable, and safe housing has been and continues to be a constant struggle for migratory and seasonal agricultural workers. A small 14% of workers may have housing provided by their employer. This is often the case for migratory workers, given that they travel for work. And this is traditionally met by growers and employers through the establishment of labor camps. Employers may recognize that lack of housing is a problem, but they are not incentivized to provide housing for migratory agricultural workers, given that the housing may be utilized for a short harvest season. Um, Construction and maintenance of this housing is difficult to keep up with, can be expensive, and therefore, a lot of times, workers receiving employer provided housing can be insufficient and substandard. However, most agricultural workers do not have housing provided by their employers, so they have to find housing on their own. Nationally, about 50% of workers report renting property for housing. However, most communities may not have enough rental units available, or they may be unavailable to agricultural workers because they cannot provide deposits, qualify in credit checks, or make long-term rental commitments due to working shorter harvest seasons. So those long-term rental commitments can be really difficult. Therefore, agricultural workers struggle to find places to live, especially in rural areas where we know housing is already limited. So some workers end up sharing rental properties with others who are working on the same farm to make it more affordable. However, much of the housing available for renting is substandard. It can be crowded if multiple workers or multiple families are sharing a housing situation. And a small 35% of agricultural workers reported owning their own private housing. This is often the case for seasonal workers who are settled out in an area, and sometimes in even private housing situations, there may be multiple families living in the same home. And in some of these crowded housing situations, as we've seen in the past couple of years here, that crowded housing can really lead to some difficult health conditions and inability to practice social distancing when needed or to quarantine, and it just makes infectious disease easier to spread. And in the absence of housing, agricultural workers may be forced to sleep in their cars, tents, ditches, or open fields. Housing does continue to be a very difficult challenge. So as mentioned, as I just mentioned, housing, there are some issues and challenges with housing, and this can lead to some health risks. Some of the common illnesses related to housing that we often see include UTIs and intestinal parasites, skin conditions and rashes, respiratory conditions, and like I just mentioned, that increased risk of infectious diseases, just to name a few. So now that we've discussed some of the conditions related to work and housing, we're going to look at the risks associated to agriculture as an occupation, as well as the environmental risks involved in agricultural work, which we know play a very big factor in health risks and occupational safety. And then we'll also talk a little bit about what regulations are in place or lack of regulations are that are available to protect agricultural workers. So to start with our occupational risks, agriculture is consistently ranked one of the three most dangerous occupations in our country, with about 368 agricultural worker related injuries and death in 2020. It's consistently ranked one of the highest reported labor trafficking occupations in the US. And immigrant workers are often the most vulnerable to these situations, such as labor trafficking, where an employer may control the movement of their workers through threats or debt bondage or other means. So there are great risks for immigrant workers in the U.S. There are also occupational risks related to the specific type of work agricultural workers do, um, just related to repetitive motions and heavy lifting. So there are injuries and disorders such as carpal tunnel, shoulder injuries, sprains and strains, low back pains and disorders. The repetitive motions and heavy lifting can cause pain and arthritis and other health problems such as that. Um, Other risks are related to the way that agricultural work is set up in general. So due to being outside all day, weather plays a big role and can contribute to heat stress and dehydration. Their agricultural workers are also at risk of insect, rodent, and snake bites, given that they're um, outdoors all day for work. Additionally, as we mentioned earlier in the presentation, there are a couple of ways that agricultural workers are typically paid. But agricultural workers that are paid with piece rate wages, which means they're paid by the piece picked versus hourly. This really encourages people to work longer, harder, and faster without taking breaks in order to earn more income. So, not taking breaks to go to the bathroom, to drink water, to rest, not having the ability to take breaks for medical appointments or managing a chronic health condition. These ways of setting up the occupation of agricultural work can really contribute to some health issues. Additionally, vehicle accidents are also a, a risk for agricultural workers for two reasons. For our migrating agricultural workers, they're on the road more than your average, than the general population, which puts you at higher risk for accidents on the road, as well as vehicle accidents where workers are transported to and from work by crew leaders, sometimes in unsafe vehicles, without seatbelts or really crowded vehicles. And then another consideration that we really saw come up throughout the COVID-19 pandemic, that lack of safety precautions that are implemented in the workplace. So not having social distancing, lack of personal protective equipment, lack of hand washing stations, and then the inability to take time off of work to quarantine if you're not feeling well. So this slide highlights some of the problems associated with field sanitation, pesticide exposure, and the environmental risks associated with agricultural work. So as we know, agricultural work often requires stooping, climbing, carrying heavy loads, working with the soil, and direct contact with plants. The direct contact with plants puts them at risk for exposure to pesticides and chemical fertilizers. So that is puts workers at risk of pesticide and chemical poisoning. There are also some plants, such as tobacco and strawberries, that release chemicals on their own that can be toxic to humans and can cause allergic reactions, such as contact dermatitis. And we know that pesticides, chemical fertilizers, and organic waste can contaminate water in or around the place of work, which can cause serious intestinal illnesses and other major issues for agricultural workers' health. The Environmental Protection Agency estimates between 10 and 20,000 poisoned agricultural workers per year. And the reason why that range is so large is because a lot of times agricultural workers who are experiencing a poisoning from pesticides or chemical fertilizers can be misdiagnosed. So sometimes they're not diagnosed correctly because the symptoms may look like something else. So that can create a challenge as well. And then sanitation and hygiene, the unavailability of safe drinking water, lack of nearby toilets, lack of nearby hand washing facilities can really increase the risk for illness and adverse health outcomes. And I'm seeing a couple of questions on definitions and sources. When we share the PowerPoint slides, there is a resource list at the end of the presentation. And on most slides where things are cited, there is a little number associating with the resource or source we found it from. So you can refer to that after the webinar. Okay, so we have covered those housing and occupational risks. And so now we're going to talk a little bit about the regulations that are in place and some of the exclusions that are specific to agricultural workers. So there are three main regulations that are in place to protect agricultural workers. The first is the Migrant and Seasonal Agricultural Worker Protection Act of 1983. This establishes the rights of agricultural workers and the guidelines that labor contractors must follow. The second is the field sanitation standard that OSHA put into place in 1987. This applies in all states and requires the availability of potable water and sanitary toilet facilities. There is a caveat to this regulation where agricultural employers of 11 or more are required to provide these safe drinking water and hand washing facilities and toilets. However, farms with 10 or fewer employees are exempt from these requirements. So the intention of this exemption was to avoid putting a financial burden on small farms, but really the result of this is that they're not required to provide very basic amenities by law to these agricultural workers. And the third regulation is the Worker Protection Standard of 1992 that was put into place by the EPA, Environmental Protection Agency. This regulation was designed to reduce pesticide poisoning and requires safety training, notification of pesticide application, the use of personal protective equipment, restricted entry after pesticide application, having decontamination supplies, and emergency medical assistance on hand. One thing that's important to remember about these regulations is that they are very dependent on enforcement on the size of the farm and the entity in charge of enforcing these regulations in the area. So this slide highlights some of the exclusions from occupational health and safety standards that agricultural workers are not included in compared to other labor groups. And the first is that agricultural workers are excluded from the right to organize and bargain collectively under the National Labor Relations Act. They're also not entitled to overtime pay under the Fair Labor Standards Act, with the exception of California as of 2016. And agricultural workers are only covered by 7 Occupational Safety and Health Administration standards. So there have been some improvements in various states. For example, like I mentioned, California in 2016, they expanded their legislation to include agricultural workers with entitlement to overtime pay. They are the first and only state to grant overtime pay to ag workers. This same governor also signed an agreement that gave agricultural workers the right to organize. However, this is many times not the case in other states. So this means agricultural workers have less protections than many other labor groups and are at greater risk of illegal and unfair treatment, injuries, and unhealthy conditions, and many other risks. So that covers our exclusions, as well as what regulations are in place. And you'll notice when it comes to the regulations in place, when we're talking about nationally, the last time there was a regulation put into place was in 1992. So that's over 30 years since updated or additional regulations were put into place to protect agricultural workers. Okay, next we're going to talk about medical conditions that are common among the population as well as barriers to care. We've touched on barriers to care throughout, but we're just going to kind of summarize those and make sure we've captured everything throughout this conversation. So if you can think of any other medical conditions or barriers to care that we're missing from the presentation, feel free to share in the chat. I know a lot of you all are on the front lines and really seeing what conditions and barriers to care agricultural workers are experiencing. So please chime in the chat. So first, we're going to look at some of the chronic conditions that agricultural workers experience according to the research. So some of the common chronic conditions include diabetes, obesity, hypertension, chronic respiratory and musculoskeletal disorders, and the primary challenge with agricultural worker patients that have chronic diseases, especially those who migrate, is that continuity of care and self-management of their chronic condition. Oral health continues to be ranked as one of the major health problems facing agricultural workers, as well as one of the biggest unmet needs as far as health services for agricultural workers. And we know that the research shows us that oral health is related to other chronic conditions such as stroke, heart and lung disease, and diabetes. And many agricultural workers do not seek oral health care until it's an emergency. There's also research showing that children of agricultural worker families are more likely to have dental issues than average US school children. As is with the general population in our country, mental health conditions are a challenge, but they are a challenge among agricultural workers. And there are a number of factors that can contribute to mental health issues. Migratory workers who are traveling alone, being separated from their family and having lack of family support can be really challenging and cause stress for those workers. Also, the lack of adequate childcare, lack of adequate education and nutrition programs for children, experiencing food insecurity, all of these things can be really stressful experiences that can lead to anxiety, depression, substance abuse, domestic violence, and other mental health conditions. And we know that cultural barriers and stigma are two big barriers to seeking mental health care that agricultural workers can face. So the next two slides here highlight some of the individual level and systems level barriers to care. So as I mentioned, we've touched on some of these throughout, but we're going to kind of summarize them here and jump in if there's anything we're missing. So at the individual level, the mobility and of migration and the long days can threaten health and pose a significant barrier to accessing care. Limited income, as we noted, many agricultural workers have a total family income below the federal poverty level, making accessing care unaffordable. This puts agricultural worker families in a predicament where they have to choose between paying for healthcare and meeting their essential needs. Many workers do not have health insurance, which forces them to seek medical care only when it's an absolute emergency or absolutely necessary. So preventative care may not be a priority. And due to limited benefits that agricultural workers receive from their employers, such as sick leave, they may not take time off work to take care of their health needs for fear of losing their jobs or losing income. One of the most commonly reported barriers is language. As we mentioned in the beginning of the presentation, over 65% of workers cited Spanish as their native language. Therefore, the inability to speak English fluently or comfortably can pose a really big barrier in accessing healthcare and understanding health education and things like that. The culture of agricultural work often gets in the way of accessing medical care. Sometimes that can be related to the occupation of limited time off, and also cultural barriers such as seeking homeopathic remedies first before seeking medical care until it's an emergency. And then lack of transportation, lack of access to technology, limited digital literacy. These are also additional barriers to accessing care. Um, and then I don't think it's, yes, unfamiliar with health benefits or community resources. This is a big one. In addition to that, just navigating the US healthcare system can be a big barrier and intimidating to take on. So navigating the healthcare system effectively in order to meet their needs can be a big challenge. So systems level, so we know there's a lot of individual barriers to care that also bleed into systems levels. But if we're taking it up to a broader level, labor policies, including lack of paid sick time and time off, is a huge barrier. Community and workplace barriers, whether that's distance from a healthcare site, workplace barriers such as lack of time off to go to appointments or take care of your health, limited healthcare sites, as I mentioned, in rural areas. We know that immigration systems and threat of deportation is a big barrier to accessing care. Exclusion from public and private health insurance, as well as a lack of awareness by many groups in our health systems and occupational systems that are not aware of the challenges faced by agricultural workers, as well as individual racism and xenophobia in communities and systemic racism in workplaces and other places in our society. So the next few slides talk about health services and how they're delivered to agricultural workers. So we know that there are some required services under the 330G programs that all migrant health centers must provide through the Migrant Health Program. That includes primary care, preventative, emergency, pharmacy, and ancillary. So most migrant health programs will provide all of these services or at least refer to all of these services. In addition to those services, migrant health centers provide outreach and enabling services. They're a crucial and critical part for the migratory and seasonal agricultural worker population. And that includes some of the services on the screen here, highlighting transportation, coordination of care, outreach, interpretation and translation. All of these are extremely important enabling services. And to kind of transition into what are some of the things that we can think about to help address some of these challenges that we've mentioned on accessing care and service delivery. And that's in our health centers, having policies, procedures, and trainings in place specific to our agricultural worker population. We know that there are individual and systems levels barriers, but there are some, and service delivery challenges, but there are some strategies that we can do at the health center level to try to address some of these challenges. And one of the big strategies that we can work on at the health center level is continuity of care. So helping, since that is a huge challenge, especially for our migrating workers and more mobile agricultural worker populations, but helping agricultural workers manage their health conditions through case management. Also self-management and health education is super important for this, and also helping migrating workers find their next healthcare destination, sending them with information on their chronic condition, what prescriptions they need, helping them find their next pharmacy. There's all kinds of strategies and continuity of care that we can consider to help support agricultural workers in managing their health and chronic conditions. So another thing that I wanted to share, if you were inspired at all at some of the information shared today or want to dive deeper into what some of those strategies are for increasing access to care for agricultural workers, we have the Increased Access to Care Network here at NCFH. This is a national network of health centers, health center controlled networks, PCAs, and other community and migrant health centers across the country that are working toward the mutual goal of increasing access to care for agricultural workers and their families. So there's a couple of ways to get involved in the IAC network. You can learn more about it on our webpage. We offer a learning collaborative, which gathers health centers from across the country to learn about increasing access to care for agricultural workers, sharing promising practices, challenges, strategies. There's guest speakers. It's a great learning collaborative to participate in. We also offer ag worker identification training through our quarterly huddles, as well as our national webinars. We offer migrant health action planning for your health center to set goals around increasing access to care. And we support you in identifying what steps and resources you need to take to reach those goals, and much more. So stay tuned on the IAC Network webpage for more information on how to get involved. We also encourage you to become a part of the Ag Worker Access campaign, and the QR code will take you to the sign up as well as the link in the chat. Through the campaign, we have lots of resources on our webpage on how you can advocate and support increasing access to care for agricultural workers. We have a quarterly update with resources, tools, and opportunities to get involved that goes out quarterly. And so if you sign up for the campaign, you're showing your commitment as an individual or as your organization to helping meet that goal of reaching 2 million agricultural workers in the health center setting. So as we're getting closer to time, I just wanted to say thank you all so much for joining us live here on the webinar. For those of you who are watching the recording of this webinar, this is where we will end. Thank you so much for joining.